Good evening, everyone. My name is Dr. Arif Al-Mullah. I am the Chief of Cardiology in Dubai Hospital. It's my pleasure for you to join us today and tonight on this webinar. This webinar is under the auspice of the Emirates Cardiac Society, and this is going to be sponsored by Bayer Pharmaceuticals. And we're going to be talking about, as everybody knows, that heart failure with preserved ejection fraction and mildly reduced ejection fraction is a challenge and has been a challenge when it comes to therapy. We are going to talk about new developments, hopefully, and new treatments coming into the management of this disease or this spectrum of the heart failure. And it's my pleasure to introduce Dr. Nushin Bazargani, who is one of our senior cardiologists in Dubai Hospital. She's predominantly involved in prevention and metabolic syndrome. And she was instrumental in forming the heart failure clinic in Dubai Hospital for a long time. Dr. Bazargani, please go ahead with your presentation.
Thank you very much, Dr. Arif. Good evening, everybody. All right. The problem of chronic kidney disease, cardiovascular disease, and metabolic disease has so much has been integrated into each other and having very, very common risk factors to the degree that now commonly we recognize this syndrome as cardio-kidney metabolic syndrome. And as you can see on the left side of my slide, you see that patients with type 2 diabetes, with chronic kidney disease and cardiovascular disease, very often they have all of these three diseases combined together simply because these three major diseases, they share the common risk factors in their pathophysiology pathway. And you can see that naturally a lot of studies that has been done in heart failure, and especially in heart failure with preserved ejection fraction, they actually have uncovered these three major metabolic disease together because these three major metabolic disease are the fundamental in the pathogenesis of the whole heart failure with preserved ejection fraction syndrome. And these pillars are not the pillars of heart failure that we often talk about as cardiologists. These are the pillars of kidneys, and this is actually has been proposed by various scientific organizations that has been listed on this slide, especially KDIGO. And these are the clinical guidelines for the management of patients who live with chronic kidney disease in type 2 diabetes. And it has been recommended that the combination of the drug therapies to optimally reduce the risk with the finerenone, which was proposed recently, has been put as a core treatment pillar among these four pillars. So these four pillars used to be the RAS inhibitors, then later the SGLT2 inhibitors came along, then GLP-1 receptor agonists came, and recently the non-steroid MRA, finerenone, was added. This pillar approach is aligned with the multifactorial and holistic approaches for the treatment of chronic kidney disease and type 2 diabetes, which is recommended by ADA and KDIGO, respectively. And how finerenone found its way among these four strong pillars for chronic kidney disease and type 2 diabetes. Before going through the studies, I just want to mention something that we have been updated, that the guidelines now recommend to measure both estimated GFR and UACR testing for patients with type 2 diabetes at least once a year, and simply because both eGFR in addition to UACR, they properly identify a stage and monitor chronic kidney disease in patients with type 2 diabetes, whereas sometimes if only you measure eGFR, you may miss the earlier stage of chronic kidney disease, and then you know that the later you notice and you recognize it, the harder it is to slow down the progression. So the testing and the UACR, in addition to eGFR, was one of the elements of these two major studies that was carried out in patients with kidney disease. So this is the Fidelo DKD and the Figaro DKD. These are large phase 3 trials that investigated the effect of finerenone on kidney and cardiovascular outcome in more than 13,000, a big number of patients who live with chronic kidney disease and type 2 diabetes. So patients were randomized to either placebo in one arm and the other arm was finerenone. The Fidelo DKD was more directed in the term of primary efficacy endpoints to the composite renal endpoint, whereas the Figaro was more directed towards the composite cardiac output point and the secondary output, which was studied in two arms. So the result of these two trials actually were combined together as a pooled study in the term of fidelity. So the fidelity is the pooled analysis or both Fidelo DKD and the Figaro DKD, and obviously, it had a big number of patients, about 13,000 patients with the follow-up of 3 years. So quite significant and a strong trial. And what did it show? So we had the cardiovascular endpoint and we had the renal endpoint. In terms of cardiovascular endpoint, we had the composite cardiovascular endpoint, which was defined as time to cardiovascular death, non-fatal MI, non-fatal stroke, or hospitalization for heart failure. And we had the relative risk reduction of 14%, and the hospitalization for heart failure with the relative risk reduction of 22%. In the kidney endpoint, the fidelity, which was a pooled analysis of these two trials, showed that the composite kidney endpoint, which was defined at time to kidney failure, sustained equal or more than 57% of eGFR decline or kidney-related death. It showed that there is a 23% reduction, relative risk reduction, and the 20% relative risk reduction of the dialysis. I want to bring to your attention to the right side of my slide And you can see the characteristic of patients who were included in this trial, and you can see that about 8% of these patients actually had prior heart failure. And RAS inhibitors in form of ACE inhibitor or ARB was used in more than 99% of patients. So no gain, no pain. What was the side effect of having one arm on finerenone? Well, obviously, there was episodes of hyperkalemia, but the clinical impact of this observation was very minimal. And you can see that, yes, we have a bigger number of patients who were reported to have hyperkalemia in the finerenone arm compared to placebo arm, but hyperkalemia leading to permanent discontinuation was very, very small, and there was absolutely no death because of hyperkalemia. And indeed, there was only 0.19 millimole of hyperkalemia was observed at 4 months of follow-up. So the robust potassium management strategy guided by their regular serum monitoring, that we will come back to that later, there were no hyperkalemia-related death in 13,000 patients that were followed up for 3 years. A big number, as I said, a big number of patients. So, and that guided the international societies into the international guidelines. And very soon you can see that finerenone found its way as class 1 recommendation in the update in the 2023 ESC guidelines for patients management, patients who had CKD and type 2 diabetes. So this was a good opening and good welcome to finerenone in overall guidelines for clinical guidelines. Now let's go back to the subject of tonight, and that is heart failure. And as Dr. Aref mentioned, we don't have a lot of information when it comes to heart failure with preserved ejection fraction. We have a lot of data for the heart failure with reduced ejection fraction. And I want you to look back and starting from 2022 and 2023. So you can see that the US on the right side of the guidelines and Europe on the left side of the guidelines. And you see that how much they have elevated SGLT2 inhibitors with evidence, with growing evidence to a higher level of recommendation for patients with heart failure with preserved ejection fraction. And you can appreciate here that this was actually the only class 1 recommendation when it comes for heart failure with more than 40%. And the rest of the medications that we still use are actually in class 2A and 2B. And again, ESC again emphasized that finerenone with the class 1A, but for patients with CKD in type 2 diabetes to reduce risk of heart failure hospitalization. Now, what to do with a disease that is growing and a disease that still we don't have enough of information and treatment for it. Currently, we are having an epidemic with the heart failure, We are facing epidemic with heart failure globally, and the prevalence is rising. We have, as usual, we don't have accurate data from our region, but I can say that in US alone, there are approximately 6 to 7 million people who are living with heart failure. And globally, about 60 to 65 million people living with heart failure. And this number is increasing. The other factor for the heart failure, and especially for heart failure with preserved ejection fraction, is that they have a lot of hospitalization, they have mortality, morbidity, the quality of their life is impacted by the disease. And we used to have this belief that only patients who have heart failure with reduced ejection fraction die, whereas all the studies have shown that even patients who have preserved ejection fraction or even patients who have mildly reduced ejection fraction also have almost the same mortality like heart failure with reduced ejection fraction. And I want to bring your attention to compare the bars of the purple bar of people who have no heart failure, their survival rate comparing to the green, blue, and black people who have heart failure. And the heart failure with preserved ejection fraction, the prevalence is increasing. It has poor prognosis, and it has increasingly hospitalization as well as heart failure with reduced ejection fraction. So we see more cases, and naturally we need more proven medications to treat these patients. We have a lot of medications in our hand, but there are not a lot of them that have been tested in the scenario of patient who has heart failure with preserved ejection fraction, with the ejection fraction more than 40%, or a patient who has mildly reduced ejection fraction. So a lot of medications on board, and apart from SGLT2 inhibitors, they are not completely strong recommendation for you to be used in heart failure with preserved ejection fraction. And even with the SGLT2 inhibitors in the heart failure with preserved ejection fraction, when it comes to inferior preserve and deliver, you can see that patients who were actually randomized to SGLT2 inhibitors, yes, they got benefit in terms of primary and secondary outcome, but still we had the residual risk. So still there is room for improvement. Still there is a need to add on to SGLT2 inhibitors to try to overcome with this residual risk. And that brings us to Fine Arts Heart Failure Trial. In Fine Art Heart Failure Trial, finerenone was investigated for its efficacy and safety superior to placebo, compared to placebo in patients who live with heart failure. So most of the effect of MRA medications comes from changes in the drivers of end organ damage that is produced by mineralocorticoid receptor overactivation. And you can see that we have this in both kidney and in heart. And a medication that has highly selective inhibition of mineralocorticoid receptors activation with the non-steroidal MRA like finerenone can be effective treatment strategy with the patients who live with the heart failure with preserved ejection fraction. And this was the question that Fine Art Heart Failure tried to address. And I want you to bring to your attention about the drivers of end organs in the term of inflammation and fibrosis and hemodynamic factors, because I think this is the area that we see things that we get when we use MRA in heart failure patients, apart from the heart failure mortality and morbidity. We see their effect in atrial fibrillation, their effect in the developing diabetes, and etc. So Fine Art had two arms, okay? So patients were randomized either to one arm, which was placebo, on top of medications that they were on, and the other arm, patients were randomized on finerenone. In finerenone, they investigated 2 doses of finerenone. If the patient's eGFR was less than 60, the initial dose was 10 milligram, and it was up titrated to maximum of 20 milligram. If the patient had eGFR of more than 60, the initial dose was 20 milligram, and it was up titrated to 40 milligram. The median follow-up was 32 months. And the primary endpoint was the number of cardiovascular deaths and total heart failure event. The secondary endpoint for total heart failure event changed from baseline to month of 6 and 9 and 12 in KCCQ-TSS, and improvement in NYHA class. So who was recruited for this study? Okay, double-blind placebo study, a study, good number of follow-up. So the inclusion criteria was any of your patients who is above age of 40, any of your patient who is diagnosed with heart failure with NYHA class 2 to 4, any of your patients who has ejection fraction equal or more than 40%, who has a structural heart abnormality, and who has pro-BNP elevation. According to most of the study design that we have, is higher in atrial fibrillation and lower if the patient is in sinus rhythm. What was the exclusion criteria? The exclusion criteria was if the eGFR was less than 25. So, and that is also, again, something to remember, because when hopefully you are prescribing finerenone, is something that you should not, you should avoid if the eGFR is less than 25 or the potassium is more than 5. And the other, again, other scenarios that comes in the exclusion criteria of other studies as well. The baseline characteristic was very much similar in both arms, in the finerenone and in the placebo. And you can see that most of the patients were in class 2, NYHA class 2, but we have 30% of patients in NYHA class 3. The mean left ventricular ejection fraction was 52. The eGFR mainly 48, and you can see that patients were already on background treatment for heart failure. So again, something specific for Fine Art, that they included patients who were recently hospitalized, or they had recent worsening of heart failure event. And you can see that on the left side of my slide, you can see the purple, the green, and the blue tells you that the days after the patient had worsening of heart failure. So this is one of the specific criteria for this study, because they included patients who were clinically ill, who had acute event, not a very stable chronic heart failure patients that we see in the clinic. In addition to that, and that is not in this slide, patients who also had improved heart failure were included in this study. And you see here on the right-hand side, the finerenone group in green and placebo group in orange, the background medications, anti-failure medications that they were on. Remember, this was not heart failure with reduced ejection fraction. This was heart failure with preserved ejection fraction. And obviously, there were a lot of diuretics used for these patients. And you can see that they were on a lot of beta blocker as well. So finerenone group, the patient who actually received finerenone on the top of anti-failure background medications for anti-failure and for other comorbidities, demonstrated a clinically meaningful of 16% relative risk reduction in composite of cardiovascular death and total heart failure event. And the difference in the treatment effect on the composite cardiovascular outcome were observed very early. So this is number one. It was observed very early, and that's why, like the other medications in heart failure, we recommend that you start them on anti-failure as early as possible, not to miss the opportunity. And number two, that it remained consistent throughout the follow-up, which was 36 months. Now, this was the first statistically significant reduction in the cardiovascular death and total heart failure event, which was observed within 1 month of finerenone initiation. And you can see here that how the curve is informative in how early it started and how sustainable it was. The statistically significant reduction in the composite cardiovascular outcome was driven by a reduction in heart failure events mainly, as it is shown in this slide, comparing placebo with finerenone. The finerenone treatment was associated with the reduction in the rate of new onset micro and macroalbuminuria versus placebo, because as you heard, finerenone was actually studied with the chronic kidney disease and diabetic patients. So obviously, in this population of heart failure with preserved ejection fraction, also it will exhibit its protection for proteinuria, which is very, very important for our patients. Another thing, that the development of new onset diabetes was observed also in this population, and it showed that compared to placebo, finerenone produced 24% reduction in patients in developing new onset diabetes, as well as atrial fibrillation, and I don't have the slide to show you for that. So the effect of finerenone treatment on reduction the risk of new onset diabetes was consistent across all 15 subgroups studies, where they eliminated BMI, waist measurements, and glycemic status of the patient. So what about the secondary endpoint? Also, finerenone had a positive effect on the secondary endpoint, the total first and recurrent heart failure event was reduced, and there was a positive trend for the changes in the KCCQ TSS result as well. So what did we pay to gain this benefit? And obviously, again, similar to other, the Fidelo and Figaro, we had hyperkalemia. But again, very similar to the previous studies, the hyperkalemia did not cause a lot of problems for our patients. Indeed, it was for the finerenone group, it was only 20.4%, and in placebo group, it was 20.6%. And we have, yes, more patients who were reported by investigators to have hyperkalemia, but very minimal number of patients had to be hospitalized for that, and we had absolutely no mortality when it comes to hyperkalemia. And I want to again remind you that we use finerenone 40 milligram for most of our patients. So the effects that we see on the primary outcome was consistent regardless of the left ventricular ejection fraction and background therapy at baseline, including the use of SGLT2 inhibitors. Because you may say now that we have SGLT2 inhibitors, maybe we do not need MRA, where this study showed that adding MRA to SGLT2 inhibitors, the non-steroid MRA to SGLT2 inhibitors, can actually have more protection in the term of primary outcome. And again, this slide is demonstrating the side effects that was studied for this population in terms of potassium. We already talked about it. Acute kidney injury, there was no difference between both arms, and the hypotension also was unremarkable. So in general, finerenone was safe to be used in this population. So finerenone demonstrated a statistically significant of 16% relative risk reduction in the composite cardiovascular outcome, the number of cardiovascular deaths and heart failure event in patients with heart failure and left ventricular ejection fraction of more than 40% compared to placebo when on the top of the background treatment. The effects of finerenone on the cardiovascular composite outcome was consistent across a broad population, regardless of baseline use of SGLT2 inhibitors or the status of their LV ejection fraction or BNP. Finerenone was well tolerated, confirming that well-known safety profile with the comparable incidence of treatment emergent side effects to placebo. Well, I don't know, but while they would love to have this pooled analysis, and this is another pooled analysis, and that is fine heart, huge number of patients in fine hearts, about 19,000 patients on finerenone. So this is an integrated pooled analysis of finerenone across 3 phase 3 trials of heart failure, chronic kidney disease, and type 2 diabetes. Remember, cardio-kidney metabolic syndrome. So, fine hearts is an integrated pooled analysis of finerenone in almost 19,000 patients across 3 phase 3 trials of heart failure and kidney disease. Finerenone has been studied in randomized controlled trials of patients who have type 2 diabetes and chronic kidney disease, and separately in patients who have heart failure plus minus type 2 diabetes and kidney disease. FINE-HEART was able to robustly assess the safety profile and efficacy of finerenone on cardiovascular death and other heart and kidney outcomes compared to individual randomized controlled trials alone. So they brought all the information together and they analyzed all these three major studies that we had, and I will repeat it for you. The FINE-HEART was for heart failure patients with preserved ejection fraction, and Fidelio and Figaro was designed for patients who have chronic kidney disease and who have diabetes type 2 plus minus mildly reduced ejection fraction or heart failure with preserved ejection fraction. This is the primary endpoint. The primary endpoint is cardiovascular composite, which is cardiovascular death and total heart failure event. And the secondary endpoint for total heart failure event and KCCQ, and which goes for mainly with FINE-HEART, and then we have the others for the Fidelity. Now, one thing I need to mention here, that definition of the endpoint of cardiovascular death differed slightly between these three trials. In the Fidelity, the death of undetermined cause was considered a cardiovascular death, but in the FINE-HEART heart failure, the death of undetermined cause was not considered to be a cardiovascular death. So definitions were harmonized in the FINE-HEART to define the primary endpoint as time to cardiovascular death, and the exclusion was undetermined death, and the pre-specified sensitivity analysis in FINE-HEART considered all undetermined death as cardiovascular death. Look at the population. Look at population in FINE-HEART, and I repeat, 19,000 patients who were studied for good number of years for follow-up. And look at the population: heart failure, chronic kidney disease, diabetes, combination of two, combination of three, and look and appreciate how much it actually reflects over clinical practice. Patients that you see either in primary healthcare setting, in heart failure clinic, in diabetic clinic, in nephrology clinic, and in internal medicine. Most of our patients, actually, all of them can be included in this circle, and most of our patients, they have either 2 or 3 of this metabolic syndrome. So it really reflects the real-world clinical setting when it comes to the characteristic of the patients. And again, you can see that across the treatment group, there were consistency across the patients in terms of EGFR, UACR, history of heart failure, and also background medication, whether patients were studied on finerenone or whether patients were on placebo arm. So the primary endpoint, again, was the cardiovascular death, excluding undetermined death, but pre-specified sensitivity analysis actually included the undetermined death. Using the primary cardiovascular outcome definition derived from the Fine Heart HF trial, finerenone was associated with a non-significant reduction in the risk of cardiovascular death because patients who had undetermined death, they were not included. So maybe they died of cardiovascular disease. We don't know, but they were not included. But when using the cardiovascular outcome definition derived from the Fidelity trial, the reduction in the risk of cardiovascular death when including undetermined death with finerenone was significant. So the design of this and the definition of the primary outcome analysis actually told us whether it was significant or not significant. And the effect of finerenone on the primary endpoint of cardiovascular death were broadly consistent regardless of the baseline use of medication, whether the patient was on SGLT2 inhibitors or GLP-1 receptor agonist. It still finerenone exhibit a beneficial effects. And again, it showed a significant benefit in pre-specified cardiovascular and kidney endpoint versus patients who did not receive finerenone. And you can see that the kidney composite endpoint, heart failure hospitalization, cardiovascular death, new onset atrial fibrillation, new onset diabetes, major cardiovascular event, and all-cause mortality were in favor of finerenone compared to placebo. And so here it is, the atrial fibrillation, atrial flutter, new onset of this arrhythmia was significantly lower in patients who received finerenone on top of other medications for their heart failure, and it was reduced by 17%, which is very important, especially for patients who live with heart failure with preserved ejection fraction, because they are elderly and they have other comorbidities like diabetes and heart failure and COPD. And the effect of finerenone in the reduction of cardiovascular death and total heart failure event and hospitalization was regardless of the initial and baseline pro-BNP level. Finerenone was associated with early and sustained reduction of the NT-proBNP for patients who receive finerenone compared to the one who did not receive. And also, when we also remove the other risk factors like age, sex, race, atrial fibrillation, BMR, EGFR, and left ventricular ejection fraction that can contribute to elevation of pro-BNP. So even when we eliminate these factors, still finerenone was associated with early and sustained reduction in pro-BNP. So to summarize, finerenone was associated with a non-significant reduction in cardiovascular death, not including unknown death, if you want to be very much precise, and not to include deaths that might or might not be due to cardiovascular disease. However, this became significant when unknown death was included. The effect of finerenone were consistent regardless of baseline medication, especially GLP and the SGLT2 inhibitors, and the level of the cardio-kidney metabolic comorbidities. Finerenone demonstrated significant benefit in other pre-specified outcomes like kidney disease, progression, and all-cause mortality and heart failure hospitalization. Finerenone was well tolerated with a well-characterized, modestly higher risk of hyperkalemia versus placebo, but overall lower incidence of serious adverse event and no excess in the risk of acute kidney injury and mortality. Now, when the indication for the heart failure, treatment of heart failure with preserved ejection fraction with finerenone arrives in UAE, like it has actually arrived in Europe, and our European colleagues are already treating patients who have heart failure with preserved ejection fraction, with ejection fraction of 40% above with finerenone. There is always the question of dosing. And I'm going to show you in 2 slides that the regime is quite simple. You don't need to remember a lot of things. So as I mentioned, finerenone has received recent FDA and EMA approval to reduce the risk of cardiovascular death, hospitalization for heart failure, and urgent heart failure visits in adult patients who live with heart failure with preserved ejection fraction, with ejection fraction of more than 40%. So the indication, as we saw in fine arts, is the adult who have heart failure with ejection fraction more than 40%, adult who have serum potassium of less than 5, and adult who have EGFR of more than 25. Now, how to initiate? So first of all, you do not initiate it if the potassium is more than 5. It doesn't mean that you don't attempt later. But if you want to initiate potassium is more than 5, you wait. Now, starting dose, it all goes back to EGFR. If EGFR is between 25 and 60, you start with 10 milligram once a day. And within 4 weeks, you up titrate it to maximum of 20 milligram once a day. If EGFR is more than 60, you initiate with 20 milligram once a day, and you up titrate it to 14 milligram maximally once a day. But since the studies in the fine arts, patients had who were having EGFR of less than 25 were excluded. So if EGFR is less than 25, you cannot initiate the treatment, but you can give the benefit of doubt to patients and try again. And of course, you measure EGFR regularly. Now, again, to be very practical, what happens if you get hyperkalemia? Because this is a real, we all sit in the clinic, and our patients are not only on MRA or finerenone, they are on other medications that can increase the potassium as well. So if after 4 weeks of initiation, you check the potassium and your potassium is less than 5, you can increase or maintain a target dose. If the potassium is between 5 and less than 5.5, you have to maintain at current dose and again check the potassium later if you want to up titrate. If potassium is more than 5.5 but less than 6, you have to decrease the finerenone to the previous dose. And if the potassium is more than 6, then you have to withhold the treatment and restart at 10 milligram if potassium arrives to less than 5.5. The recommendation that has been done in these studies with a big number of patients, good number of years of follow-up, was that they measured the serum potassium after 4 weeks of treatment initiation. To give you a safe practice regime. And with that, I would like to thank you for your attention. We'll be glad to answer any question that you might have.
Thank you very much, Dr. Nasheen. First of all, I will actually ask a few questions myself, then we'll go to the Q&A. There are a few Q&As have been asked. So regarding the finerenone, right? It's a non-steroidal uh, mineralocorticoid receptor antagonist. Uh, Spironolactone and eplerenone are currently indicated in heart failure with reduced ejection fraction, and they're both steroidal. Do you really think that there is really a difference between these drugs? If, let's say, the steroidal drugs were used in addition, let's say, to the finerenone in preserved ejection fraction, or
Yeah.
do you see no, actually, that finerenone is has proven itself?
Yeah. So as you said, spironolactone and eplerenone, no doubt their efficacy in patients with heart failure with reduced ejection fraction. None of them have been used and studied in patients with heart failure with preserved ejection fraction, except spironolactone. Actually, spironolactone was studied in the SPIRIT trial that aimed to compare spironolactone, compare it to placebo in patients with preserved the heart failure with preserved ejection
You
fraction.
mean the top cat?
No, no, not Topcat, Spirit. Spirit is another study, but unfortunately, Spirit study was actually faced with the COVID problem. So they ended up of having 75% less predicted event and 50% less predicted number of patients. They
Mm.
concluded the study that there was no significant difference between the spironolactone and placebo in patients with heart failure with preserved ejection fraction. But we cannot make any conclusion out of it because it was not power enough, because it faced the COVID and the fund problem and everything. But I would like you to look it up, a spread study. Now, definitely in the structure of the non-steroid MRA, like finerenone, there are certain difference between them to the steroidal, and that they don't have the steroidal morphology, they don't have the steroidal and hormonal side effect like gynecomastia. They are more specific to the receptor, they have higher affinity to the receptor, they have more balanced distribution in both heart and kidney. Now, all of these are in their mode of action and in the theory. Now, whether spironolactone and eplerenone can be can demonstrate the same benefit, we don't know. Can actually the non-steroid exhibit the same benefit in heart failure with reduced ejection fraction like we saw with spironolactone with eplerenone? We don't know. We know what the study showed us. So we have these facts for heart failure with preserved ejection fraction.
How commonly do you see gynecomastia in real practice, real world practice, right? With spironolactone or steroidal mineralocorticoid receptor antagonists?
Yeah, we both run heart failure clinic. It's not that common. You can always switch them to eplerenone, so it's not that common. And sometimes they are actually on digoxin as well, so we don't know which one is causing what. But we don't see. I don't see. I see cases, but not that common. It's not as common as incidence of hyperkalemia that we see for these patients because they
Yeah.
are taking other medications that can cause hyperkalemia as well.
One of the things that caught my eye in your slides is
Mm-hmm.
that one out of four people,
Mm-hmm.
it reduced, risk of developing diabetes, finerenone, and heart
It,
failure, which is,
yeah,
I believe, is a significant uh, number of patients.
Yes.
Uh, do you know the mechanism? Because we have not seen, or I think, I guess, in subgroup analysis with eplerenone or spironolactone.
It has been observed in rare study with spironolactone as well, but not this
Mhm.
much, this number. But I think it goes to the effect of proteinuria because I run the cardiometabolic clinic now, Dr. Arif. Really, it is a good drug to reduction of the of proteinuria. And I have seen patients that actually, as you have seen patients in your heart failure clinic, that they improve their ejection fraction. I have seen patients that actually with the medication, this medication, they actually reduce their protein in the urine, which is very good because it's a marker for the severity and progression of the disease. So perhaps it goes back to that.
So I'm going to go now to the questions.
Yes.
One of the questions is by one of the attendees. They're asking that they have patients with resistant hypertension on spironolactone, and they also have heart failure with preserved ejection fraction. How would you include finerenone in this subtype of patients? Would you stop the spironolactone and start the finerenone, or what would you do exactly?
Yeah. Uh, this question was asked actually at the panel when this study was presented in Heart Failure Association of European Society of Cardiology, and we had a panel of European, Canadian, and Americans. Of course, the symposium was sponsored by Bayer. All of them, they said we will switch. So they said we will switch. We have to be more practical. If the patient is doing well on spironolactone, yes, we have strong evidence of the now finerenone. But if he's doing well, we have to consider other things, availability, affordability of the medication. But if there is a room for improvement, we can switch. And how to switch also is important because you cannot just, because the patient's hypertensive also, you cannot just stop the spironolactone and switch them. I think the recommendation is to down titrate spironolactone slowly, then stop it, and then add finerenone. But
Okay.
in general, MRA in higher dose has been shown to be beneficial in reduction of blood pressure as well.
Okay. The other question is in patients with preserved or mildly reduced ejection fraction, would you start the finerenone sequentially or at the same time as SGLT2 and diuretics?
First of all, diuretics they usually they need it. The study that I presented, they were already on both diuretics and SGLT2 inhibitors. Um, I think it's all depends on the kidney function, depends on the blood pressure. The new trend is you start all the medications together with the smaller dose and then try to upgrade slowly all the medications or the pillars together. The good thing about combination of the finerenone and SGLT2 inhibitors is that SGLT2 inhibitors does not have any effect on potassium. So combination of both actually does not give you any trouble regarding the potassium. But I would like to ask the question to you actually, you run heart failure clinic. And this is a good question because there is no absolute correct answer for this question. How would you actually you treat a lot of patients with preserved ejection fraction heart failure? Would you do MRA and SGLT2 together? Um, I know the answer.
So I would tell you, if the
Yeah.
patient is congested, yes, I would start them together. If they're not congested, I will do it in a sequential way.
Mm,
So
yeah,
it will really depend on congestion.
just yeah.
Because
Okay.
then, if the patient is congested, both drugs will actually act together synergistically and rid of the body of the congestion. But if the patient is not congested, you don't want to also lead to worsening EGFR and increase the risk of hyperkalemia.
Yeah. The only thing that I want to add here is that both SGLT2 inhibitors and finerenone, they showed they exhibit their beneficial effect at very early stage of disease. So to take that opportunity, you should not delay the initiation of the medication if clinically possible. This is one. The second thing, when the patient is inpatient, when you start any medication, usually the compliance to that medication is better than if you start the medication in heart failure clinic or in general cardiology clinic. So these are the opportunities that if clinically we are allowed to start them together, it's a good thing to take these opportunities for the better compliance of patients.
Okay. Um, Another question is, it's a long question. They're asking, yeah, so if the trial was 3 years, right, and the reduction was 16%, right, especially total heart failure events, uh, is there an open label extension? That's one. And the second thing is, would you continue beyond the 3 years of therapy, considering that this trial was 3 years?
I don't think that there was open label extension. Bayer may be definite about it, but I don't think. Now, we have been. It's not only this study. It's not only fine art study. We have been involved in a lot of studies. We have been involved even in eplerenone phase 3 studies. We have been involved in the inclisiran studies. So when the study finish and we see good outcome for your patients, it is actually unethical to drop the medication from your patient. So obviously we continue unless the patient has serious side effect or patient doesn't want to continue medication because you see the effects. I think it's highly unethical. It's because you finish the study, you drop the patient out of the medication.
Okay. Another question is, there was an effect on, as I said, the diabetes, right? Reduction. And there was also reduction in AF. Was there any AF subtype looked at, like paroxysmal, persistent, permanent, or just in general AF?
No, the first incidence of AF, the first onset of AF and atrial flutter, both.
Okay.
But nothing mentioned about is paroxysmal, permanent, or anything.
I think a few more. Just a second. Somebody's actually writing along questions. I'm not sure what is the purpose of the question. We don't know what, so I guess in a way they're asking about hyperkalemia and potassium, right? But I would put what they're trying to see is that if, let's say, you have a baseline potassium, let's say you have an EGFR between 25 and 60, okay, but the baseline potassium is above 5, okay, but less than 5.5. Would you consider giving potassium binders? And you know that we have now more potassium binders, right, than the old potassium binder, calcium, what do you call it, resonium. And then start, once the potassium goes down, would you start the finerenone?
Yeah, this
Or
is
would you
actually.
know, because this was not studied, yeah?
No, it was not a study, but this was actually proposal of the other pharmaceutics that have potassium binders, not only for the finerenone, but for the other MRA and for the ARNI, that if your patients has this tendency of hyperkalemia, you start them on potassium binders, stabilize the potassium, then you will be able to start the anti-failure medications. I know we didn't try it, but definitely if the patient on finerenone or other anti-failure medications and they have hyperkalemia, we commonly use potassium binder actually.
Okay. Uh, I think this you probably answered. The question is, would you switch patients who are on spironolactone or eplerenone to finerenone? I would probably say, in HFrEF right now, you don't have any evidence for finerenone, so no, I would not reduce that. I would not change that. In HFpEF, I believe, as you said earlier, if they already have been stable on the other medications, there is really no strong reason to switch. If the other medications are already preventing any heart failure hospitalization, and finerenone really drove predominantly heart failure hospitalization. And I don't know if you have anything else to add to what I just said.
No, absolutely agree with you.
Uh, surely. So they're saying, how often would you, in real practice, check potassium if you're going to start finerenone?
Yeah, it's the recommendation is 4 weeks actually
But
after
would you do
initiation.
it? Would you do it
Yeah,
more
after,
closely
yeah.
if you see that there is an increase in potassium? Do you think that 4 weeks is long for a drug that has the risk of hyperkalemia, especially in patients, let's say, who have lower GFRs?
Okay, yes, if the patient has low GFR and is already using other medication that can increase the potassium, definitely you need to bring them earlier to check their potassium.
Okay.
But in more stable patients, after initiation of the small dose of finerenone, because we don't initiate with the higher dose, we use a smaller dose first initially. So the recommendation is 4 weeks. Bring them, check the potassium, then up titrate.
Okay. Here's shorter questions. I skipped them earlier. But one question is they're asking is, why is inflammation and fibrosis important in heart failure progression?
Yeah, now inflammation, fibrosis are all being identified in the pathophysiology of heart failure and a lot of cardiovascular disease, even ischemic heart disease, and that's why we have tests like high sensitive CRP, We are seeing some activities in developing medications that actually aim at the reduction of inflammation. So recently, it has been recognized as one of the physiological factors in the development of heart failure and cardiovascular disease.
Right. I guess, and you already have talked about the dosing because there's one question about the dosing. You already mentioned it that if it's EGFR 25 to 60, it's 10 and then 20, and if it's above 60, it's 20 to 40. Uh, um, and I think that's it really. Thank you very much. And I forgot to mention to the attendees that this is CME accredited by Dubai Health Authority for 1 hour or one CME credit. And this will be sent to everybody through the survey. And after answering the surveys, everybody will get hopefully their certifications. Thank you very much, Dr. Nushin, for this nice presentation. And hopefully we'll see more of this, inshallah. And thank you very much and have a good
Thank you.
night.
Thank you.
And
Thank
good
you very
night
much.
for
Thank
everyone
you.
attending. Thank you for attending with us.